So let's get started. So the session today is it's called Genetics Don't Lie. We're talking about the genetics of cancer. Thank you for joining us. I am Dr. Dan Platt, the Chief Medical Officer of Grit Health. I'm so excited to have you here and also so excited to have a great panel of guests who I'll introduce in just a minute. As a reminder, we are not going to be offering medical advice, specific medical advice. We'll be talking about things in general. This is meant to be educational and informational. Any discussions about your own treatment are discussions you should be having with your doctor. We will try to answer some questions from the audience though, and kind of keep things a little bit broader so that they might be applicable to a number of people. And we're excited to field those questions. You can put those questions in the chat or in the Q&A at the bottom of the screen, and we will get them. And our friends will send them over to me to ask, and we'll get them out to the panelists. Genetics, really complicated issue, and something that a lot of patients tend to struggle with. It can be super complex. It's becoming a much more important part of treatment and prognosis, and understanding things like whether someone's going to recur. So your genetic makeup and the genetic makeup of your cancer, which is called genomics, and we'll talk a little bit more about this in a second, they're the biggest determinants of cancer risk, the treatment you receive and the effectiveness of the treatment. And it has never been more important to understand the role that genetics plays. And it's something that, like I said, a lot of patients tend to struggle with. It comes into the discussion in a couple different ways, and we'll try to tease those apart for you today. In this session, like I said, we're going to talk about with a panel of experts. We're going to answer your questions. We're going to hopefully clear up some of the misconceptions around the genetics of cancer, and we're going to talk about it hopefully in a patient-friendly way. As questions come in, that'll help us clarify. So please keep those questions coming. We want you to leave the session with a better understanding of the impact of genetics in cancer and what it means for you and your family. I'm going to start by introducing our great set of panelists. I would like to first throw it over to Nicole to introduce herself. Thank you so much for being here, and welcome to the discussion.
Thank you. My name is Nicole Bailey, and I was diagnosed in 2012 as at age 34 with stage 3 breast cancer. And then 4 years later, at the age of 38, I became stage 4. I am a survivor now, and I currently just finished a clinical trial at the University of Virginia. I'm BRCA2 positive, and I am hormone positive, ER negative, and I am a wife, mom of 3 beautiful children, and I'm living currently in Bentonville, Arkansas.
Awesome. Thank you, Nicole. Upal, if you could introduce yourself.
Hi, everyone. My name is Upal Vasuroy, and it's such an honor and a privilege to be on this great panel. And thank you, Grit Health, for having me. I am currently the Executive Director of Research at Longevity Foundation, a lung cancer patient advocacy group. I trained in cancer biology, both as a PhD student and as a postdoc, and I'm incredibly interested in the intersection of genetics, genomics, and patient care in cancer.
Thank you, Paul. So just a pleasure to have you here, as it always is. And thank you so much to Longevity for being a friend of Grit Health through the years. TJ, if we could pass it over to you.
Yeah, hi, everyone. My name's TJ Bowen. I'm the Chief Scientific Officer at a company called Deep Lens, and we really try to find cancer survivors who are interested in finding clinical research the right treatments for them. My background is, I'm like Upal, I have a background in a PhD in cancer genetics. Did my research a long time ago, and I always tell everybody it's really nice to see the world evolving, because I'm sure, as Upal can say, we knew that oncogenes and genetics was really important back in the day, but it's really nice to see there being targeted therapies coming around. So I'm excited to talk about it today.
Awesome. Thank you, TJ. So before we jump into the panel discussion, we are going to bring up some slides and just do kind of a brief overview of some of the key points around cancer genetics and genomics. This is a chance for also people in the audience to ask a few questions if we can clarify some things up front. So I'm going to open up the slides right now. So the first thing to emphasize is that cancer is the accumulation of mutations. And while this is pretty well known among a lot of patients, it's something that can be somewhat confusing because there's a lot of different ways that mutations happen in cancer. And it's not just one mutation, as this picture shows, it's a number of mutations that need to develop in order for someone to actually develop cancer. So a mutation in itself is not uncommon. Mutations happen all the time. Sorry about that. They're a normal consequence of the healthy division of your cells. And usually your body, basically when a cell mutates, it either usually dies because it's unhealthy, because it had the mutation, or a lot of times your immune system can clear it, can destroy that cell that's been mutated, recognizes it, kills it. This is why things like immunotherapy that we talked about earlier can be really useful, because they basically use the system your body already has in place to destroy cancer. But every day, and this is really important to understand, your body develops thousands of mutations. And like I just mentioned, a lot of those don't actually result in anything that's dangerous or hazardous, or the body just gets rid of the cell and nothing ends up happening. Sometimes, though, mutations can arise in a way that gives these cells unique abilities. It makes them either divide very rapidly. Sometimes they can grow on top of each other and kind of stack up, which is something that cells can't normally do. Sometimes they can become metastatic. They can become metastatic, They can develop the ability to spread and grow in other places that aren't the normal place they would grow. So these kind of buildup of special unique abilities is what makes cancer different than your typical mutation. And as it says here, cancer refers to a group of these mutations, and they have to accumulate over time. And it's not until usually you get multiple mutations that a cancer really develops and is able to escape all the mechanisms that your body uses to control cell growth. So that's the general gist of kind of where cancer comes from and how the mutations that happen, that we're going to be able to talk about in a second, that are targeted, enable cancer to grow, but can also be targets for treatment. So I'm going to move on to the next slide here and pass it over to TJ.
Yeah, so really briefly, I think it's important for everybody to understand the difference between the way cancer genomics and genetics are described. And as Dan said, mutations occur all the time in your body. I think it's really important to know that it's a normal part of everybody's life. Sun causes damage, oxidative damage. There's all kinds of damage, but your body is actually really well equipped to deal with that damage. We have a lot of different mechanisms that go through and actually fix DNA damage. But when you're actually talking about the damage on the DNA level, that's when you hear people refer to genomics. Your genome is all the cumulative DNA that actually leads to the outcomes of hereditary, what you turn into as an adult or as a kid. So when you hear your physicians talking about genomics, they're really talking about where you have specific mutations within the genome. So a normal genome, as Dan said, it's going to have a lot of different mutations happening here and there, and most of those get fixed. And the ones that are really bad, typically apoptosis or some other mechanisms, kills those cells, and you're no worse for the wear. But every once in a while, the system breaks down, and I talk to people about this like it's a game of Battleship. It's like there's constantly mutations happening all over the place. And it's only when you have accumulation of those mutations that the battleship gets sunk. And that specific cell, it has to happen not only to different specific genes, but it has to happen in a same cell, right? If it happens in different cells, it doesn't lead to the cancer. So the genome is really about that. Now, if we talk about the genetics, what we're really talking about is your hereditary effects. So you get genes passed down from your mom and genes passed down from your dad. And, depending on some of those mutations are inherited, that's your genetics. So as Nicole said, she's BRCA2 positive, which means she has a mutation in the gene BRCA2, and that was inherited. from her parents. That doesn't always necessarily mean you're going to get cancer either, right? So as Dan said, you have to have multiple accumulation of mutations happen. But what it does do is it gives you, unfortunately, a head start. So, you see a lot of patients that are, BRCA1, BRCA2, EGFR. There's a lot of mutations that have a predisposition to lead to early cancer. So when you hear your physicians talk about your genetics, they're talking about your hereditary predisposition to get a disease. And typically, typically this is when you're asked about your medical history and your parents and your grandparents and your aunts and uncles to really understand sort of what predisposition you have.
Awesome. Thanks, TJ. And pass it over to you, Paul. Talk about targeted therapy.
Thanks, Dan and TJ, for setting up this slide really well. I'm going to sort of go first to biomarkers, and Dan and TJ talked about genetics and genomics. And let's talk about genomics a little bit, which is looking at changes in your DNA at a very specific level. And genomic changes typically lead to changes in proteins which come from DNA. And sometimes these proteins can lead to cancer. And these proteins are often called biomarkers. And sometimes these genomic changes can also be called biomarkers as well. So essentially, a biomarker is a unique characteristic of a cancer cell that can either help in identifying the cancer cell, or a biomarker essentially makes sure that a cancer cell can grow very fast. And that is why biomarkers are incredibly attractive targets for drug development, which is what leads us to targeted therapies. A targeted therapy is a very specific kind of drug that attacks or inhibits a specific biomarker. Now, when we're thinking of chemotherapy, keep in mind that chemotherapy is somewhat indiscriminate. It attacks both normal cells as well as cancer cells. But targeted therapies are very unique in that they specifically stop the growth of those cells that have a specific biomarker. And let's use an example here of the EGFR, or the epidermal growth factor receptor. Now, this particular protein, the EGFR protein, is present on the surface of lung cancer cells or in colon cancer cells, which is what you see on the right side, which is a figure, and you see a cell below, and then you see an inset that's showing you the EGFR receptor. Now, when this receptor is active, or it's signaling for the cancer cell to grow, then the cancer starts growing. But then you have an EGFR inhibitor, which is the pill that you see right there. This particular EGFR inhibitor blocks this particular signaling and stops the growth of cancer cells. And keep in mind that this particular drug will only work on those cells that have the EGFR protein. So again, making it very specific. And I'm going to go back to what Nicole mentioned when she was sharing her story with us. She said that she is ER negative, which is estrogen receptor negative. Now that again is a biomarker in breast cancer. And had her cancer been positive for ER, then she might have been eligible for a different type of treatment. So keeping in mind that it's very, very important for us to know what types of biomarkers cancers have so we can customize and target those biomarkers.
I'm sorry. I'm ER positive.
I apologize, Nicole, for the mistake.
ER positive and her new negative.
Okay.
Yeah. So that means, Nicole, what were you given a specific drug for like ER positive, like Upal was saying? Probably yes, but not maybe a drug for HER2 negative.
Or HER2
targets, right? Yeah. So.
And also, I would like to add on to the genetic part of it. My mother passed away from breast cancer. Her father passed away from prostate cancer. So I know that with the BRCA2, prostate, pancreatic, skin, and breast and ovarian all fall into that umbrella. And so we think it probably started with my mom's father, since he had the prostate cancer, although they were never genetically tested. So, but my mom passed, I have it. And then we just found out that our 18-year-old daughter has BRCA as well.
Yeah, we should definitely talk more about kind of understanding the family history. And Nicole, I'm sorry to hear that news. I think we'll jump in. I just first want to quickly kind of make sure that we're all on the same page. So a quick review. So Nicole is talking about her heredity. So she's talking about her genetics, and that means the genetics that she inherited from her mother and father. In this case, because Nicole inherited a specific gene mutation, she was predisposed to have cancer, as it sounds like many of the people in her family were. And that's a genetic mutation that's been passed down in Nicole's family over time. Now, the difference is that when Nicole developed cancer, the genomics came into play. The genomics are the genetics of the cancer. It's confusing, but her cells started to change a little bit more, and that's why cancer developed. And it's those genomics that we're going to target, and it's the biomarkers that fit into the genomics of cancer. So those are what enable us to target Nicole's ER receptor, for instance. So I hope we're all on the same page. If there are any questions about any of this, please feel free to drop them in the chat, and we'll try to clarify a little bit more. With that, I would love to jump back to you, Nicole, and talk a little bit about how you first found out that you were BRCA2 positive, and kind of what that's led to. And I know you started to mention it, but I would love to hear more.
Yeah. So in 2012, that's when I was diagnosed, and I went and had a mammogram. I didn't expect to hear anything that day. So I went by myself. And like I said, we had only lived here for 9 months. We were originally from Pennsylvania, and had moved to Arkansas for my husband's work. And we were recently moved, not even a year, and didn't really know a lot of people. So my husband came home for lunch, stayed with the kids because it was spring break, and I went to my mammogram, and they ended up telling me that day that it was cancer, and that they asked me if I wanted to be genetically tested, and I said yes. And so it was just a simple swish and spit, but it was very expensive. And that was in 2012. And now you can do it from your house, and it's relatively cheap now. And so I highly suggest it for anybody who is recently diagnosed, because it helps you to make decisions about your future care or your future surgery decisions. Because I mean, some of the decisions you have to make, or that I had to make, were like, lumpectomy versus mastectomy, single or double. I'm trying to think what else there was. Even radiation versus no radiation, complete hysterectomy versus a partial hysterectomy. And so there's a lot of decisions you have to make once you find out that you are a BRCA carrier. And so, even if you're not a BRCA carrier, you still have to make decisions. So anybody that's recently diagnosed, or even if you're not diagnosed, should get your genetic testing done.
Yeah, it's really important, Nicole. Thank you for mentioning that. Can you talk a little bit about what it was like, how your doctor spoke to you about BRCA2, BRCA2, and kind of how he or she explained it to you? And then did you see a genetic counselor at all when you were first going through your diagnosis?
I had a health nurse navigator She's the one that did the genetic testing. And she's also the one that called and told me the results. I don't believe I ever talked to a doctor about that. Because they all worked so fast in the beginning. And I felt like there was a lot of stuff being thrown at me. And the BRCA testing was one of those things that I was just like, wow, there's so much happening right now. And I don't even know left from right. And it was hard to even retain all the information that was coming at me because there was so much happening. And so I honestly can't remember a doctor telling me that I had the BRCA gene. I think it was the nurse navigator that ended up telling me. And yeah.
No, Nicole, thank you for bringing that up, because I think it's a really useful experience to talk about. That this is at a time when you're being diagnosed, it's a really hectic time. It's overwhelming. And this
Very
other
much.
added thing of genetics of that you need to understand is incredibly complicated. And so it can be something that's during that period of time, it can be something that's really hard to grasp. It can be something that that it takes time and understanding to develop. And I thank you for mentioning this, because I think it's even more important that you kind of realize that you don't really remember how you were how you were educated about it and where you got the information from, because it was just there was so much going on at that time. So I think a lot of patients are also a lot of other patients will be in that position of so much happening at once, and this is another thing that you need to kind of understand. So really, thank you for bringing that up.
Yes, and it's very important to take notes, because unless you have somebody with you, there's just so much happening. And if you can take notes or, just jot stuff down immediately afterwards, it'll help keep you, in the moment and remember things. So, because it's hard. There's a lot going on.
Absolutely. Great point. And if you can record, you can record on your phone or something like that. That's a great way to kind of take notes as well. And you can always go back and play it and, and learn a little bit and review it. So that's another gret strategy. I'd like to pass it over to TJ now. So TJ, you mentioned for your research for your PhD, I'd focus on the identification of mutations like BRCA in breast cancer. How did that work impact your current interest in genetic testing to identify patients for research?
Yeah, I think it was fundamental. There were really two events that really got me interested in where I ended up now. One was my aunt had ovarian cancer, and seeing the challenges she had getting the right treatments was something that really impacted me. And then the other was my research, and just like I said earlier, knowing that there's these very specific mutations. There's a few hundred genes that are really important for the escape of cells to become cancer. And knowing that back, 20 something years ago, but just not seeing the availability of treatment for that. They give chemotherapy, which is a great option in the beginning, but it's sort of like the nuclear weapon, and it's really nice to see that if you can understand what's happening at the cellular level, like at the molecule level within a cancer, that you can actually target cancer. They say that cancer is actually many, many different diseases. So, Nicole's cancer is different than my aunt's cancer is different than everyone else's cancer, because like you said, Dan, it's multiple genes, and there's hundreds of different genes that could be mutated that can lead to that cancer. So each one is a very specific disease in itself. And getting your genomic test is really important, because you can understand exactly which of those genes are problematic. And, nowadays there's a lot of really good targeted therapies that will go specifically for those mutations. So looking back at my research, I just think knowing then that these things were happening, and then watching and seeing it progress over the last 20 years and seeing how many new targeted therapies are coming out, it's really great. And our mission is just to make sure that all patients get access to those treatments, because you first have to be aware, and then secondarily you have to get access. And so that's just super important.
Awesome. Thank you, TJ. That's a great response.
Sure.
We're getting some questions in the chat around mutations and explaining them a little bit more.
Yeah.
And so one of the things that I think is really useful to understand is, as TJ was saying, and as we've talked about a little bit, cancer is accumulation of mutations. And but the way those mutations happen, it can happen for different reasons. So TJ mentioned UV light, like sun causing mutations in your skin cells that would lead to skin cancer. Other things like cigarettes and nicotine can cause mutations because they introduce mutations. They can cause mutations because they're toxic and the cells need to divide, and then the mutation causes cancer to grow. So those are some of the ways that mutations can happen. And then there are many different ways that people check genetics. So for instance, when someone is getting, say, in vitro fertilization, or when someone is looking, and I know we got a question about this, they will look at the genetics of the embryo in order to understand if there are any mutations that might predispose to a disease. They're not checking all, and they're usually not checking cancer genetics or like cancer mutations. They're checking other ones that may result in things like Down syndrome or other inherited genetic diseases. So that's another use of genetics, is to understand the potential for developing disease. And that's exactly what we're talking about when in Nicole's case, is that she had an increased potential for developing cancer because of that BRCA2 gene. So I hope that makes things a little bit clearer. If not, please continue to put your questions in the chat, and I can hopefully clear it, and the rest of us here can clear up some of those. I'd like to pass it over to Paul now. So unlike breast cancer, there are kind of fewer genetic risk factors identified for lung cancer. However, lung cancer is an area where there's a ton of new treatments coming out, targeted treatments, and they've been very successful. And they look at genomic sequencing in order to figure out whether those drugs would work for people. So I'm wondering, can you briefly explain how genomics and targeted therapies have impacted lung cancer treatment? And are there learnings about genomics from lung cancer that can be applied to other types of cancer?
Absolutely, Dan. Thank you for that question. And going back to what TJ mentioned during his discussion about genomics, it's really looking at changes at the DNA level in a cancer cell. And the idea of genomics is to sort of really give us that insider view of what's unique to a particular type of cancer. And I think this is incredibly important to keep in mind, that different cancers may have some common mutations, but at the end of the day, the biology of a particular mutation is very unique to that type of cancer. So all this is to say that every cancer is unique, and genomics helps us understand what that unique aspect of a cancer is, and how can we use that information to come up with a customized treatment. And I think lung cancer is a great example of how genomics has played a role in our understanding of new treatments for lung cancer. Now, when I was doing my graduate work in 2004, the only information that we had about lung cancer at that time was about this gene called KRAS. We knew that the KRAS gene is often mutated in patients with lung cancer, but we didn't know how to use that information because we didn't have any drugs. And that was actually the year when my uncle was diagnosed with lung cancer, and we didn't know what to do because there was no information available. But flash forward to 2021, and keep in mind that various initiatives like the Human Genome Project happened in the late 2000s. Then the Cancer Genome Atlas happened in the late 2000s and early 2010s. So essentially, these two big projects gave us a very, very good insight of the genomics of different types of cancer, and lung cancer being one of them. And with this information, we were able to understand that there are certain unique genomic changes in lung cancer, and these unique changes can be targeted with different pills. And speaking again in 2021, now we have targeted pills for 9 different genomic changes in lung cancer. And this is incredibly important to keep in mind because we need to have this information. So when a patient is diagnosed with lung cancer, a comprehensive and thorough genomic profiling is recommended so we can identify if any of these different changes are present and make sure that the right treatment is matched to the unique genomic makeup of that lung cancer. So again, in 2004, we had no treatments. The only option we had is chemotherapy. But in 2021, we have 9 different biomarker treatments for lung cancer based on our understanding of genomics. And again, the way we see it is lung cancer is sort of really leading the forefront of precision medicine, because what is the goal of precision medicine? The goal of precision medicine is to really match the right patient with the right treatment at the right time. And we have been able to see that in lung cancer. And it is leading the forefront of genomic medicine as well. And what are some of those lessons that have sort of percolated into other cancers? The one that comes to mind is pancreatic cancer. Now, I mentioned that lung cancers tend to have a mutation in the KRAS gene. Pancreatic cancer is another cancer which has mutations in the KRAS gene. And now we have a treatment for a type of KRAS gene, a KRAS mutation in lung cancer. And that information is driving drug development in pancreatic cancer. So again, shared genomic changes, but very unique features that now we are able to translate into therapy.
Yeah, thanks, Upal. Great response. It's you're absolutely right. It's really kind of about recognizing genetic changes across tumors as opposed to within one specific cancer type. We're getting some questions in the chat. I just want to emphasize, unfortunately, we're not able to address specific medical questions, but we will be able to talk about things in a little bit more generic terms. TJ, a question for you. An audience member asked, TJ decided to research which cancers, and I think breast cancer was the main one, but many patients, like this audience member, are often told you're a unique case. How are rare or unique cases studied?
Yeah, so that's a great question. I mean, it's really challenging, to be honest, because when you have an incidence that's really low, you have a tough time finding patients. So a lot of times that's done epidemiologically, which just means that you look back at the case history to see patients who had been treated that had a very similar sort of case history to the person that is now being treated. So in ultra rare cancer cases, you have to look back and see what treatments had worked previously. The great thing is, though, now they're starting to kind of change the way clinical trials are being run. And they're running new types of trials called basket studies. And what that means is, instead of historically, if you were a lung cancer patient or a breast cancer patient, you would go on a breast cancer trial. They're starting to create studies now that span across the tumor type, whether it's lung, breast, colon, and look more at the genetics. So if you have a specific rare gene, they're now creating different cohorts of patients regardless of what tissue it manifests in, to see if the gene underlying that cancer is actually resulting. So I'm hopeful that moving forward, we're going to have a lot more luck and data supporting these really rare types of cancers, because usually the rarity is a result of a specific mutation. So like I said, historically they look epidemiologically, they look backward in time, but moving forward, they're going to be able to put you on a study that sort of is catered more to the genetics. Yeah,
great point, TJ. And the thing that I love to bring up here is big data, and the fact that as we get more understanding about the genome that an individual patient has with their cancer, and we're able to put all that information in one place, then the next time the next patient who gets tested, they may have a completely new cancer with different mutations that have never occurred in a combination before. But now we know what treatments are used for individual mutations. And now we can maybe tailor and figure out, hey, these 3 drugs would work really well for this patient, maybe because of the gene changes they have. So right. It's a really exciting time to be involved in this. And thank you so much, TJ, for your answer to that question.
Yeah, real quick, Dan, another great resource Upal already mentioned, which is the Cancer Genome Atlas project, which happened several years ago. But, physicians have access to a lot of the data that underlies that program. So they can look back and see where there was a specific very rare mutation, if a patient has that, and then they can look into the research and really try to understand what the treatment programs were. So that was a huge kind of seminal project that was done about 10 years ago.
Yeah, it's a really important project. It's really interesting to check out. I want to pass it over to Nicole for a question. So one of the questions that's coming up in the chat a lot is, how can I get genetically tested for cancer? Nicole, I was wondering if you could tell us kind of what the steps were in you getting genetically tested. It sounds like it kind of came up pretty early, but do you have anything that you would recommend for patients to ask about getting genetically tested?
So my daughter just got genetically tested, and hers was also a swish and spit. She saw a genetic counselor, and but what I want to recommend before you get tested is make sure that you have life insurance. The reason I say that is if you test positive, your life insurance may cost a lot more. I don't know that, but we got her life insurance before we got her tested, because if not, and she tested positive like she did, you usually have to fill out medical questions. And I would think, because I already have breast cancer and her grandmother already passed from breast cancer, that already boosts her monthly price up. And then if she had to answer a question like, have you ever tested positive for BRCA, that would really boost it up. So we just got it just in case. And so that's something to think about before you get tested, or have a daughter to get tested, or a son. They say that you can't get tested until you're 18. So when McKenna turned 18, we made sure she had insurance, and then we got her tested, and it came back positive. As a mother, that was very devastating, because you feel guilty and you take the fault for that, and it's a hard thing to deal with. And but she's a very mature girl, and she's just like, I'll just get a prophylactic mastectomy. And she's like, it's not that big of a deal, Mom. Thanks. I'm just like, are you kidding me? Is this a big deal? But she's like nonchalant about it, and it's crazy. And but she doesn't care. And I shouldn't say she doesn't care, but she's like, it's not a big deal, Mom. And that's what I'll do. And so that's her plan as of now. And she's my only one that's old enough to get tested. So we're starting with her. And like I said, she's probably the 4th generation now. And yep. I forget what you even asked me. I'm sorry.
Thank you for talking about this, Nicole. I'm sure it's something that's very hard to discuss. I'm sorry to hear that she tested positive. I'm happy to hear that she's dealing with it in such a positive way. You mentioned prophylactic mastectomy. What has that kind of been like, talking to her about that? And can you explain a little bit more to the audience kind of what that means and why that's a decision that you guys are making right now? Yeah.
So a prophylactic mastectomy is when when you choose to have your breast removed before you develop cancer. And so because she tested positive for the BRCA gene, we don't know if that means she'll get breast cancer or not, but there's a higher risk for her. And so for breast and ovarian cancer is very high. The other cancers that I mentioned earlier, like prostate, skin, and pancreatic, they're all a little bit lower, but she is, she doesn't think it's that big of a deal just to have her breast removed. And she doesn't plan on breastfeeding if she has children. And so she's fine with that. And I'm just like, holy smokes. I mean, her and I are both a part of a group called the Breasties. And it's like a support group. And she's good. She's good with it. And, I'm like, there's so many things that can go wrong, but she's not afraid.
Yeah, that's the big thing. She's not afraid, Nicole. She sounds like a really brave person. So I'm glad that she's able to deal with this in a really, it sounds like, mature way. I think it's congratulations to you for raising a daughter who's able to handle something like this. That's so difficult. We're getting a question in the chat that I really want to address, and we're getting so many great questions, by the way. We won't be able to address them all, most likely. But there's a question here. My biggest fear is transferring my cancer cells to my future children. What can I do on my end? Is there any test I may not be aware of? So there's a really important thing we have to talk about related to that question, which is the difference between Nicole's experience and someone who's developed what we call a de novo mutation, a de novo cancer. So Nicole had BRCA2 positivity, which led to an increased risk of developing cancer. And someone who's just developed a new cancer that might come about may not be in the genes that you send on to your children. It's most likely that it's what's called a somatic mutation, a mutation of a body cell that happens for chance or because of the sun hitting your skin and causing that mutation. So usually cancer is not passed on. And it's in the rare circumstances where someone has a mutation in their what are called germline cells, the sperm cells, the egg cells, that you can get it passed on generation to generation. Upal, TJ, I don't know if there's something that you want to clarify around that, but it's a really, really important question to differentiate and understand and make sure that we're on the same page. So I want to pass it over in case you guys have anything you'd like to say.
I think the only thing, Dan, that I would add is that every mutation in the same gene also doesn't have to be inherited. For example, you can have mutations in the BRCA gene that may not be passed on to your children, and that may actually be a somatic mutation.
Yeah.
So that's a good point, Upal. Yep.
Yeah, so it's really making sure when you go to get genetically tested, make sure to ask your doctor, are they testing your genes, your hereditary genes, so the genes that are in every cell in your body, or are they testing your cancer genome, which are just the genes in your cancer? And of course, the cancer is going to be have many more mutations than your typical cell. So they're going to compare those two to figure that out. I'd like to jump to another question here. Let's see. With a metastasis, and this particular person's was a colorectal cancer metastasis, do you recommend a complete new testing of the tumor? Do biomarkers change? This is a really great question. Upal, since you started to talk a little bit about biomarkers earlier, is this one that you feel comfortable taking?
I can attempt, Dan. I think that's a very, very good question. And there is a lot of evidence that now shows that the primary cancer, or when I say the primary cancer, the cancer that started in a particular tissue, it could be lung cancer, it could be breast cancer, the biomarkers in that particular cancer, the primary cancer, may be somewhat different than biomarkers that's found in a cancer that's metastasized. So let's take, for an example, lung cancer. So you have a primary lung cancer site in the lung, and then the patient may have a metastases in the liver. And the biomarkers in these two places may be the same or they may be different. And it's actually important for us to understand what the biomarkers in this unique site are, because it tells us how the cancer is changing and what these changes are, so we can target them, so we can, of course, block the metastases, but also make sure that future metastases do not happen.
Awesome. Great. Thank you, Upal, for taking that one on. We have time for just a few more questions. And I want to make sure that we get to some interesting points. I think it's important to talk about cancer genetic testing and talk a little bit more. Upal, you've been mentioning biomarkers. Which patient so it's become so much more important across a number of different types of cancer to understand the genetics of that cancer. Are there some types, and TJ, I'd love to throw this question over to you. Are there some types of cancer where understanding where it hasn't been developed as much, or kind of where have targeted therapies played a bigger role, and where is there still work to do?
Yeah, that's a good question. I think obviously in the more prevalent disease, biomarkers have been sort of brought to the forefront. So breast, colorectal, lung, pancreatic, some of the ones that are deadly too. But, I think what we're seeing is that, a lot of these mutations, like we've talked about, are random. They're happening in any tissue. And just the nature of where those mutations happen is actually where the site of the cancer can develop. So you can get a BRCA1 mutation in any cell. It just so happens that breast and ovarian tend to be the most prominent because those tissues regenerate a lot. They change a lot. Same thing with lung. Lung is a very common place to get cancer, right? Because those tissues are the ones that are processing out all of the pollutants. So they get a lot of toxicity. But any tissue can get those random mutations and stack up. So what I would say is they're finding a lot of the therapies that are being targeted are targeted to those highly prevalent and incident diseases. But that doesn't mean they're not going to apply to some of the more rare diseases. And I think that's what we're starting to see happen with some of these new trials that are starting to come out, where you can start to see they're approaching specific targets for a gene across multiple different types of cancers, which is great. I think that's going to be amazing. I would say, you have to talk to your physician about which of these diseases are going to be covered by insurance and which ones, NCCN has guidelines around which should be tested for. But I think the good promising news that I can say without giving anybody any advice is that these tests are they're getting less expensive. They're becoming more common. They're becoming more prevalent. So there's a lot of different groups out there that are running these tests. So I think, it's safe to say that over the next few years or so that the tests are going to become a lot more common.
Absolutely. And they're also getting a lot cheaper, TJ, which is really important.
Yeah.
One important thing you mentioned that I think would be really useful for a couple of the questions that are coming through to understand is the difference between solid tumors, where there's a lot of genetic testing going on, and some of the liquid tumors, and understanding the reason why there's not as much in liquid tumors. And that's because those cells tend to be very specific to a very specific type of disease. So for instance, AML or acute myelogenous leukemia, the cells that those patients have tend to look the same patient to patient. And so because we know that, we can still use targeted therapies, but there isn't as much of a need to test the patient to understand their genetics, because we're pretty sure it's in what are called B cells, for instance, or T cells. And we're pretty sure we know what that's going to show. And so in those patients, they actually don't need to be genetically tested, but you're still using targeted therapies to treat them. So that's a really important point to understand. I want to now, we have to wrap up, unfortunately, and there's so many great so many great questions that I haven't been able to address. I hope that we can, have a session in the near future. Maybe Lauren, if you're watching, we can set something up to have for Grit Health to discuss this in more and answer some of these other questions. But as a finishing point, I'd love to pass it off to Nicole. We've talked about so many of the challenges that have come up with dealing with your hereditary cancer mutation. You've talked about your daughter and the challenges that she has faced. I'm wondering, for you, what has been the biggest takeaway from this experience, and how have you been able to to deal with the challenges? How have you been able to find that support that you mentioned? What's been important to you, and what would you say to other patients who are newly diagnosed?
So I recently, like I said earlier, I went through a trial at the University of Virginia. It was hard, and it was 2 months away from my family. We live here in Arkansas. I had to be in Virginia, and I left on August, I think it was 15th, and I didn't come back until October 15th. And it was very hard. It was hard being away from them. It was hard mentally, emotionally, physically. And every side effect that could have happened to me. High fevers, high pulse rate, low blood pressure, pain, everything. It was bad, and it was hard. And they wanted me to come back in a month. However, they didn't provide any compensation. And they didn't tell me until it was like a week away. And Angel flights needed more time. To catch a flight was very expensive when you only have a week to plan. And so, unfortunately, I dropped out of the trial, and it was only going to be a follow-up. I had already completed all the medication. It was just going to be labs and a scan. And I could do that here in Arkansas, but they refused to let me do that here. And so I just had my scan last Friday, and it appears like it's not working because I have larger tumors in the omentum area in my stomach. So that's kind of upsetting. But they're going to send for the scans that I had done in Virginia and compare them and see how they were then versus now. So I still have a lot of hope yet, but I was really hoping that this was going to be my miracle. So, but anyway, enough of that sad stuff. And again, I lost track of what your question was.
It's okay, Nicole. I'm sorry to hear that things are difficult right now. Maybe we can end on a positive note and, just give thanks that, you're still with us and you're still able to come and join us for this discussion and help educate all the audience. And it's been such a pleasure having you here to tell us about your case, and you've been exceptionally brave. So we can't thank you enough, both from Grit Health and I'm sure from TJ at Deep Lens and from Upal with Longevity. I want to give Upal, TJ, do you have anything that you'd like to kind of say as we start to sign off?
No, I just thank you guys. Thank Grit Health for inviting me. I get so much out of meeting people like Nicole, It's just amazing to see how strong people are, and that, you know, we're fighting for you and we pull for you all the time. We're praying for you. We want you guys to do well. So thank you guys. And I just think, you know, educating everybody we can about what they can do is really important. So this is great. Thank you, Dan, for having us.
Thank you, TJ. And thank you to all the panelists. Thank you so much to you, the audience, for joining us today and for asking such great questions. We look forward to helping you out more. And please stay here for the next session is going to be, and let me just pull this up. We are going to, when the session ends, you're going to have to go back to GVCC21.com, log in, and from the homepage, you're going to be able to join the next one. It'll say happening now. If you have any questions, you can type them in the chat, and my friends and the other colleagues at Grit Health will help you find the session that you need. But again, thank you so much for being here, and thank you to the panelists, and hope you have a great rest of your day.